Discuss about the carbapenems here. Most of us are familiar with them. They have been in use more than 30 years, one of the most commonly used antibiotics in the intensive care unit and also in the hospital setting. And that is because they have a broad spectrum, they are very new, and they were into the clinical picture because they could overcome a lot of resistance from the previous beta lactams. They are active both on gram positive and gram negative, as well as on the anaerobes. And the utility was that they are active against many beta lactamase producing organisms, especially the ESBL and AMC types. We still need to understand that it does not have appreciable activity against enterococci, against MRSA. So it works on MSSA but does not work on MRSA, as multiphilia, and among the carbapenemase, the MBL types, metallobetalactamases, and obviously against bacteria which do not have cell wall. They are not active. They are available since 1985 when imipenem was the first agent to be used, and they have been used in wide range of infections. So maybe all across the body, any infection, carbapenem could be of use. The agents that we have available with us is imipenem, meropenem, doripenem, biapenem, and artopenem, and we'll see the subtle differences and similarities between them. Imipenem has the highest risk of seizures, almost up to 3 to 4%, which would be probably double or more than that seen with meropenem. And it does not have excellent CNS penetration, so whenever we have CNS infections, we would like to avoid imipenem and use meropenem. Some gram-negative bacteria are inherently resistant, like Proteus, Providentia, Moragnella. So even when we are doing laboratory testing, we do attach the fact that they might be inherently resistant to imipenem. Somehow it has a better gram-positive cover, but as I said, only for MSSA, not for MRSA, and that could be better than meropenem. When it comes to Pseudomonas, both meropenem and doripenem are favored agents. Doripenem also has lower MICs for many of the GNBs, and it's not known if that would be of any therapeutic benefit. Artopenem is a narrow spectrum. It has no pseudomonal activity. So when we have ruled out pseudomonal infection, this might be ones that we can use. It's the one which has a long half-life, so it can be used in a once daily dose. There is an intramuscular option as well. So among the outpatient carbapenems, probably artopenem is the one which is most commonly used, provided there is no pseudomonal infection. Biapenem, recently available in India but has been there for long. It is also supposed to have lower seizure risk. And in India, the DGCI is approved it for complicated UTIs. It may offer advantage against drug-resistant enterobacterials, that's what's said. So some of the carbapenem, other carbapenem-resistant enterobacterials, maybe we can try biapenem, and it could be a better agent for Pseudomonas. We all know about the menace of carbapenem resistance, and we'd just like to visit it here. The commonest one is obviously elaboration of the various carbapenemases, serine types and the metallobetalactamases type. But there are two other defects, like the protein binding site abnormalities. And MRSA is one such agent, so a gram-positive agent which has actually produced a binding site change and has developed resistance to carbapenem. So carbapenems are not useful for MRSA. This protein binding site changes may also be seen in gram-negative organisms. Then porin defects. Basically, we all know that the gram-negative bacterial cell wall is covered by an outer membrane. And for the cell wall active agents, they have to cross the membrane and reach the area where they work. Porin channels are water channels, and since these antibiotics are water soluble and small in size, they negotiate through these channels and reach their site of activity. So if there are defects in porin channels, they may not be able to reach the site. And also there are efflux pumps employed at the site, so sometimes the antibiotic can be thrown out. One of the strategies that we have adopted for carbapenem resistance, one is high dose prolonged infusion of meropenem 2 grams IV over 3 hours thrice daily. People have even used it 6 hourly. Combination therapy, obviously, where the carbapenem is retained, and the addition of novel BLIs even to carbapenems, like meropenem with vevorbactam and imipenem cilastatin with relibactam, which has really extended the spectrum of the carbapenems. This is all was just like a recap of carbapenems, and I hope that it helps you now in a little decision making whenever you are using a carbapenem.